Coronary blood vessels. Coronary arteries. Heart muscle is supplied by two coronary arteries, namely right and left coronary arteries, which are the first branches of aorta. Arteries encircle the heart in the manner of a crown, hence the name coronary arteries, Latin word corona equals crown. Right and left coronary arteries. Right coronary artery supplies whole of the right ventricle and posterior portion of left ventricle. Left coronary artery supplies mainly the anterior and lateral parts of left ventricle. There are many variations in diameter of coronary arteries. Variations in coronary arteries. In 50% to 60% of human beings, the right coronary artery is larger, right dominant, and supplies more blood to heart than left coronary artery. In 15% to 20% of human beings, the left coronary artery is larger, left dominant. In 20% to 30% of human beings, both arteries supply almost equal amount of blood. Branches of coronary arteries. Coronary arteries divide and subdivide into smaller branches, which run all along the surface of the heart. Smaller branches are called epicardiac arteries and give rise to further smaller branches known as final arteries or intramural vessels. Final arteries run at right angles through the heart muscle, near the inner aspect of wall of the heart. Venous drainage. Venous drainage from heart muscle is by three types of vessels. Coronary sinus. Coronary sinus is the larger vein draining 75% of total coronary flow. It drains blood from left side of the heart and opens into right atrium near tricuspid valve. Anterior coronary veins. Anterior coronary veins drain blood from right side of the heart and open directly into right atrium. Thebacean veins. Thebacean veins drain deoxygenated blood from myocardium, directly into the concerned chamber of the heart. Physiological shunt. Physiological shunt is the diverted route, diversion, through which the venous, deoxygenated, blood is mixed with arterial blood. Deoxygenated blood flowing from Thebacean veins into cardiac chambers makes up the part of normal physiological shunt. Other component of physiological shunt is the drainage of deoxygenated blood from bronchial circulation into pulmonary vein, without being oxygenated. Coronary blood flow and its measurement. Normal coronary blood flow. Normal blood flow through coronary circulation is about 200 ml/minute. It forms 4% of cardiac output. It is about 65 to 70 ml/minute/100 g of cardiac muscle. Measurement of coronary blood flow. Direct method. Coronary blood flow is measured by using an electromagnetic flow meter. It is directly placed around any coronary artery. Refer Chapter 98 for details of electromagnetic flow meter. By Fick principle. Coronary blood flow is measured by applying Fick principle, Chapter 98, using nitrous oxide, N2O. The subject is asked to inhale a known quantity of the gas with atmospheric air. Then, blood samples are collected from an artery and from coronary sinus, by using a catheter. The blood flow is determined by using the formula, amount of NO taken up/minute blood flow equals arteriovenous difference of N2O content by using Doppler flow meter. Piezoelectric crystals are used in the Doppler flow meter probe, to transmit and receive the pulses of high-frequency sound waves, Chapter 98. The Doppler flow meter probe is mounted to a catheter and positioned at the ostium of right or left coronary artery to measure the velocity of phasic flow of blood. The cross-sectional area of the artery is determined by angiography. From velocity of blood flow and cross-sectional area, the volume of blood flow is calculated. By videodensitometry. Videodensitometry is the technique used to measure both velocity of blood flow and the cross-sectional area of coronary arteries, simultaneously. From these two values, the coronary blood flow can be calculated. Phasic changes in coronary blood flow. Blood flow through coronary arteries is not constant. It decreases during systole and increases during diastole, Fig 108.1. Intramural vessels or final arteries supplying myocardium are perpendicular to the cardiac muscles. So, During systole, the intramural vessels are compressed and blood flow is reduced. During diastole, the compression is released and the blood vessels are distended. So, the blood flow increases. Phasic changes in left ventricle. In left ventricle, during the onset of isometric contraction, blood flow declines sharply due to two reasons, namely increase in myocardial tissue pressure and decrease in aortic pressure. During ejection period, rise in aortic pressure causes a sharp rise in flow into left coronary artery. However, the flow of blood through coronary capillaries is less. It is due to the high intramural myocardial pressure in the contracting ventricle. Decreased blood flow is maintained until the closure of aortic valve, i.e. till the end of systole. During the onset of diastole, blood flow rises and it reaches the peak sharply. During the later part of diastole, the flow is reduced slightly along with decreasing aortic pressure. Once again, there is a sharp fall in flow during the onset of systole. Phasic changes in right ventricle. A small amount of blood flows into right ventricle during systole. It is because the force of contraction is not as severe as in the case of left ventricle. Still, the amount of blood flowing is very much less than that during diastole. Factors regulating coronary blood flow. Autoregulation. Like any other organ, heart also has the capacity to regulate its own blood flow by autoregulation, Chapter 102. Coronary blood flow is not affected when mean arterial pressure varies between 60 and 150 mm Hg. Several factors are involved in the autoregulation mechanism. 1. Need for oxygen. Oxygen is the most important factor maintaining blood flow through the coronary blood vessels. Amount of blood passing through coronary circulation is directly proportional to the consumption of oxygen by cardiac muscle. Even in resting condition, a large amount of oxygen, i.e. 70% to 80% is consumed from the blood by heart muscle than by any other tissues. In conditions associated with increased cardiac activity, the need for oxygen increases enormously. Thus, the need for oxygen, i.e. hypoxia, immediately causes coronary vasodilatation and increases the blood flow to heart. 2. Metabolic factors. Coronary vasodilatation during hypoxic conditions occurs because of some metabolic products, which increase the coronary blood flow by vasodilatation. Reactive hyperemia. Reactive hyperemia is the increase in blood flow due to the vasodilator effects of metabolites. Metabolic products which increase the coronary blood flow. Adenosine. Adenosine is a potent vasodilator and it increases the blood flow to cardiac muscle. During hypoxia, ATP in the muscle is degraded in large amount, forming ADP. Some ADP molecules are further degraded into adenosine, which is released into tissue fluids of heart muscle. Other substances which increase the coronary blood flow by vasodilatation are potassium, hydrogen, carbon dioxide, adenosine phosphate compounds. 3. Coronary perfusion pressure. Perfusion pressure is the balance between mean arterial pressure and venous pressure, Chapter 102. Thus, coronary perfusion pressure is the balance between mean arterial pressure in aorta and the right atrial pressure. Since right arterial pressure is low, the mean arterial pressure becomes the major factor that maintains the coronary blood flow. Range of mean arterial pressure at which the coronary blood flow can be maintained is given above. 4. Nervous factors. Coronary blood vessels are innervated both by parasympathetic and sympathetic divisions of autonomic nervous system. It is not known whether the autonomic nerves have direct effect on blood flow in various conditions. However, these nerves influence the coronary blood flow indirectly by acting on the musculature of heart. For example, stimulation of sympathetic nerves increases the rate and force of contraction of heart. This in turn causes liberation of more metabolites which dilate the blood vessels and increase the coronary blood flow. Similarly, when parasympathetic nerves are stimulated, the cardiac functions are inhibited and the production of metabolites is less. Coronary blood flow decreases. Applied physiology, coronary artery disease. Coronary artery disease, CAD, is the heart disease that is caused by inadequate blood supply to cardiac muscle due to occlusion of coronary artery. It is also called coronary heart disease. Coronary occlusion. Definition. Coronary occlusion is the partial or complete obstruction of the coronary artery. Cause. Coronary occlusion is caused by atherosclerosis, a condition associated with deposition of cholesterol on the walls of the artery. In due course, this part of the arterial wall becomes fibrotic and it is called atherosclerotic plaque. The plaque is made up of cholesterol, calcium, and other substances from blood. Because of the atherosclerotic plaque, the lumen of the coronary artery becomes narrow. In severe conditions, the artery is completely occluded. Development of atherosclerotic plaque is common in coronary arteries near the origin from aorta. This plaque activates platelets, resulting in thrombosis, and the blood clot is called thrombus. When 3/4 of the lumen of the coronary artery is obstructed either by atherosclerotic plaque or thrombus, the blood flow to myocardium is reduced. It results in ischemia of myocardium. Coronary thrombosis is associated with spasm of coronary artery. Smaller blood vessels are occluded by the thrombus or part of atherosclerotic plaque, detached from coronary artery. This thrombus or part of the plaque is called embolus. Myocardial ischemia and necrosis. Myocardial ischemia. Myocardial ischemia is the reaction of a part of myocardium in response to hypoxia. Hypoxia develops when blood flow to a part of myocardium decreases severely due to occlusion of a coronary artery. Blood flow is usually restored if a small quantum of myocardium is affected by ischemia due to obstruction of smaller blood vessels. It is due to rapid development of coronary collateral arteries. Necrosis. Necrosis refers to death of cells or tissues by injury or disease in a localized area. Ischemia leads to necrosis of myocardium if a large part of myocardium is involved or the occlusion is severe involving larger blood vessels. Necrosis is irreversible. Myocardial infarction, heart attack. Myocardial infarction is the necrosis of myocardium caused by insufficient blood flow due to embolus, thrombus or vascular spasm. It is also called heart attack. In myocardial infarction, death occurs rapidly due to ventricular fibrillation. Myocardial stunning. Myocardial stunning is a type of transient mechanical dysfunction of heart, caused by a mild reduction in blood flow. A substantial reduction in coronary blood flow causes ischemia followed by necrosis. A mild reduction in blood flow causes only ischemia and it may not be sufficient to cause necrosis of myocardium. However, it produces some transient, short-lived, mechanical disturbances or dysfunction of the heart. Since it is short-lived, heart recovers completely from this. Symptoms of myocardial infarction. Common symptoms of myocardial infarction: cardiac pain, nausea, vomiting, palpitations, difficulty in breathing, extreme weakness, sweating, anxiety, cardiac pain, angina pectoris. Cardiac pain is the chest pain that is caused by myocardial ischemia. It is also called angina pectoris. It is the common manifestation of coronary artery disease. Pain starts beneath the sternum and radiates to the surface of left arm and left shoulder. Cardiac pain is a referred pain and it is felt over the body, away from heart. It is because heart and left arm develop from the same dermatomal segment in embryo. Cause for cardiac pain. Ischemia is mainly due to hypoxia. During myocardial ischemia, there is accumulation of anaerobic metabolic end products such as uric acid. Metabolites and other pain-producing substances like substance P, histamine, and kinin stimulate the sensory nerve endings, leading to pain. Sensory pathway. Sensory pathway from the heart is as follows: inferior cervical sympathetic nerve fibers, chapter 101, carrying the sensations of pain, or stretch, from the heart reach the posterior gray horn of first-fourth thoracic segments of spinal cord. Here, these fibers synapse with second-order neurons, substantial gelatinosa of Rolando, of lateral spinothalamic tract. Fibers from substantial gelatinosa of Rolando form lateral spinothalamic tract and reach the sensory cortex via thalamus. If hypoxia in myocardium is relieved by coronary collateral circulation or by treatment, the pain-producing substances are washed away by blood flow. Chronic angina pectoris. In chronic angina pectoris, the patient does not feel the pain normally. The pain is felt only when the workload of heart increases. The workload of the heart increases in conditions like exercise and emotional outburst. When the frequency of angina attack increases, the patient is prone to develop acute myocardial infarction. Treatment for angina pectoris. By using drugs. Vasodilator drugs. Vasodilator drugs like glycerol trinitrate or sodium nitrite relieve the pain by dilating coronary arteries. However, the main therapeutic effect of such drugs is to dilate splanchnic blood vessels, which cause reduction in venous return, cardiac output, workload of the heart and oxygen consumption in myocardium so that, release of pain-promoting substances is inhibited. Calcium channel blockers. These drugs block the influx of calcium into the cells. When calcium influx is blocked, the myocardial contractility and workload of the heart are decreased. Sympathetic blocking agents. Sympathetic blocking agents like propranolol, beta blockers, block the beta-adrenergic receptors and inhibit the cardiac activity. This decreases heart rate, stroke volume, workload on heart and oxygen consumption. It also stops the production of nociceptive substances in myocardium. By surgical methods. Aortic coronary artery bypass graft. Part of myocardium affected by coronary occlusion is detected by angiography. Then, the anastomosis is made between aorta and the coronary artery beyond occlusion, by a technique called aortic coronary artery bypass graft. Mostly, a small vein from lower limb is used for anastomosis. Though this method can relieve the pain, it is not useful if the myocardium is damaged extensively. Percutaneous transluminal coronary angioplasty, PTCA. Laser coronary angioplasty.